I'd like to move on to, I think, the fourth part of our afternoon. Hello, I'll introduce myself. I'm Alex Wee. I'm a doctor from the UK, and I'm practice at a place called Frimley Park Hospital, which is just outside London. It's a district general hospital. It has a catchment population of 1 million. And we have what we call a diabetic multidisciplinary team comprising of a vascular surgeon, orthopedic surgeon, that's me, endocrinologists, podiatry, tissue nurses, tissue wound nurses, and endocrine or diabetology nurses as well. So as part of my practice, I also undertake regular trauma and orthopedic surgery, what I call my vanilla surgery, nice and clean, very plain, very straightforward. I also do Charcot reconstructions, and what I'm going to talk to you about today, when I finally share my slides, what I'm going to talk to you about today is prophylactic surgery for the Charcot foot. Okay, so just a little background, more background. Initially, I come to this forum or this meeting as a skeptic, but having heard all the fascinating talks earlier this morning or this afternoon for me, I now have my curiosity piqued, and I think I will be looking more into this TTT technique for treating diabetic foot ulcers. But in reality, I appeal to the audience really as a financial realist. As you all know, the NHS, the National Health Service, is a severely resource limited system where the automatic response to anything new that costs money is no. And really, I'm trying to talk to the audience out there about ways of preventing and mitigating the Charcot process and the complications of Charcot. So hopefully after this talk, you'll have some simple takeaway ideas and take that and adopt that into your practice if you haven't already. So why do prophylactic surgery? Well, it's certainly a lot easier than reconstruction or TTT. I think as orthopedic surgeons, we're all very familiar with how to cut bone, but having to deal with pin sites, wound breakages, wound breakdowns, metal breakages, prophylactic surgery is quick, it's simple, it's a lot less stressful as well. It also has been shown to reduce the complications and the infections with Charcot. And as we all know, infection will lead to greater complexity of the salvage, operation, or reconstruction surgery that Charcots have to undergo. So when do we do the surgery? When do we do prophylactic surgery? Well, when they're neuropathic and there's evidence of overload and deformity. So what is evidence of overload? We're all familiar with increased callosities and deformities are very clinically evident. But I think you have to look for these signs. Sometimes they present subtly, and in many cases, I think, as an earlier presenter mentioned, that Charcot is often missed and signs of overload are often missed. And it's only when they present with an ulcer that the problem becomes extremely apparent. So the function of offloading surgery is to reduce foot pressures, remove the bony prominences, and in doing so, you can also downgrade the Charcot process and therefore stop further problems from arising. So I'm going to review a little bit about arches and arch anatomy, how the arch fails, the forces that go through the foot in normal and abnormal feet, consequences of neuropathy, Charcot and secondary mechanical changes, and offloading surgical techniques. So we're all familiar with engineering concepts. The arch works with a keystone that has to be sloped, and this allows vertical transmission of force through the voussoirs, the stones that form the rest of the arch of the that go down into the vertical supports, and the force transmits through the sides down and outwards. And stone and bone has great compressive strength. The foot arches, just a brief reminder, the transverse arch, the intermediate cuneiform is our keystone. The medial longitudinal arch has the talus, and the cuboid and the mid-tarsal bone segment forms the keystone for the lateral longitudinal arch. And these are the forces that act on the foot and the keystones. And you can see the downward force of your body weight, the upward pull of the tendo Achilles and tibialis anterior, and the ground reaction forces going through the metatarsal heads and the calcaneum. A brief reminder that it's not all about bone. The soft tissues play an important structure, and we're all familiar with the tensioning and guy rope effect of the long and short plantar ligaments, the peroneal tendons, tib post and tibant, and they all form part of the structures that protect the arch. And the three arch supports or essentially allows a vault-like structure. And a vault is a self-supporting arch. And what do we store in the vault? We store all the things that are precious to us. And in the foot, that is our clockwork, our neurovascular bundles. They're all stored in that part of the foot, protected by the vault. And when the vault collapses, they become very vulnerable. So the soft tissues, the plantar fascia tendons and the ligaments hold the shape and maintain the stiffness and allows the body weight to be transmitted and supported from the hind foot to the forefoot and back to the hind foot once again during the entire gait cycle. So the purpose of the soft tissue allows the change of the shape of the long arch to make it stiffer as a lever. And it allows transmission from the hind to the forefoot during the gait cycle. The arch fails, as we know, in tension on the concave side. You can see cracking in the bone, and this is where the Charcot process comes in. The bone starts to disintegrate, the integrity of the arch is disrupted, and you get failure on the tension side due to the increased loading as well. And these diagrams represent arch failure in the foot. So with a progressive equinus of a tight Achilles complex, the dorsiflexion moment on the forefoot with weight bearing and increased forefoot pressure with the action of tibialis anterior, this accentuates the deformity and results in a rocker bottom foot. And you can see what happens. There's dorsal escape at the Lisfranc or the tarsometatarsal joint level. There is a dissociation and disruption of Meares line. The tendo Achilles pulls the calcaneum up. You get a decrease in calcaneal pitch, and that results with that very marked and severe Charcot deformity. And this is the effect, the pressure effect on the medial arch skin due to the with a midfoot rocker deformity. And once again, we're familiar with these shapes from very mild Charcot, just some red hot swelling on the top left to the top right. The swelling's more apparent, and then you start seeing the rocker bottom deformities with hindfoot and a skew foot on the bottom left and the bottom right images. The transverse arch collapse, you can see midfoot collapse. The talar-navicular joint has been disrupted. And on the right-hand image, you can see disruption at both talar-navicular joint, at the tarsometatarsal joint and the navicular cuneiform joint, and a similar sort of deformity on the left foot with a bilateral Charcot. With failure of the lateral arch, you get dropping of the cuboid. And this is one of the more pernicious and dangerous deformities. They often present with lateral plantar ulcers, which do very badly with offloading and therefore often lead to surgical reconstruction and stabilization. So the idea is to get to the foot before they develop these problems. So increase with a tight tendo Achilles, we're all familiar with the increase in forefoot loading with a tight tendo Achilles, and this leads to forefoot ulceration, as this Peter barograph demonstrates. And so the strategies and the thinking behind offloading surgery is to neutralize the force and to remove points of attrition and contact with the floor or with the ground, and avoid forefoot ulcers, midfoot ulcers, and hindfoot ulcers. So starting proximally with calf lengthening or calf releases. In zone 1, in the mid-substance of the calf, you can undertake a proximal gastrocnemius release. I'll talk about that. That's not shown on these diagrams. Strea releases at the lower end where the triceps surae forms. You can release that aponeurosis very effectively with a distal gastrocnemius recession as well. And then if you have a significant tendo Achilles contracture, one can undertake a Hoke triple hemisection to release that tendon. Some people undertake a Z lengthening of the tendon, but that has to be done open and the tendon repaired. So why is the proximal medial gastrocnemius head released in preference to the lateral? Because it's thicker and you get a more profound release and relief of forefoot pressures. It's up to 2.4 times thicker in cross-sectional area than the lateral head of gastro. It's a fairly simple procedure which I can undertake under a local anesthetic and a light sedation, and patients are up immediately and mobilizing fairly quickly. There's minimal morbidity with it. The Hoke triple hemisection, I know some of my UK colleagues undertake this in clinic. I do not have that facility, so I will take these patients to theatre and perform a straightforward Hoke triple hemi. Usually it's done in combination with other procedures, but we're all familiar with the technique. And what are the results of the plantar pressures after release? Well, we know that neuropaths have very high plantar pressures during the gait cycle, up to 100 Newton centimeters squared. And in a non-neuropathic foot, this is up to about 45 Newton centimeters squared. Following Achilles lengthening, tendo Achilles lengthening, the plantar pressures can drop to 63 at 2 months. And it's been shown by Armstrong, Brodsky, and more recently by my colleague Tr&Orth, that plantar pressures can be reduced by 27 to 34% when measured after tendo Achilles lengthening. So Mary Tr&Orth is another diabetic Charcot surgeon in Basildon. It's in Essex. And he looked at his results for tendo Achilles lengthening in his Charcot feet as part of a prophylactic treatment. And he performed TALs in 146 feet. After that, he put them in TCCs and he followed them up for 1 year. And he found that 92 feet, or 96% of his patients had ulcer healing within 10 weeks. 12 feet had recurrent ulcers or failed to heal. Those 12 went on to have metatarsal osteotomies to elevate the metatarsals, and they all underwent healing later on. He also identified an improvement in the calcaneal pitch by an average of 6 degrees. And he also noted that cuboid height was improved in 3 out of 4 feet in stage 2B disease. So he surmised that the severity or the process of the Charcot process had been mitigated or slowed down at least. We're all familiar with the claw toe deformity or the hammer toe deformity resulting in ulceration on the apex of the dorsum of the PIP joint, the imbalance of the long flexors and the intrinsics causing a hyperextension and a flexion, hyperextension at the MTP joint and a flexion at the PIP joint. With attenuation of the fat pad, leading to ulceration underneath the metatarsal head. This is treated and dealt with by a fairly straightforward percutaneous flexor tenotomy. This can be done simply and often without anesthetic because they are neuropathic. This I do in clinic, and I try and encourage and educate my podiatric colleagues to undertake this sort of procedure in clinic as well when they see these patients without me. So Anderson looked at his results of needle tenotomies, and in his group of 81 feet, he undertook 104 tenotomies, and just a third had type 1 diabetes. He did 36 tenotomies for ulcers on the foot, and he found that 34 out of that 36 healed in an average time of 28 days. Prophylactic tenotomies were done in 84 patients. He noted that 6 patients developed an ulcer. There were no serious complications, infections, or amputations recorded in his group. Moving on to Charcot-Exostectomy, essentially taking the prominence off so it doesn't rub against the skin and create an ulcer. Some technique slides. It's a fairly straightforward and relatively satisfying procedure. However, looking at the literature, luminaries from Brodsky, Meyerson, Rosenblum, Lorena Vinciane, and Wieman all found mixed results, with between 50 to 75% of their patients experiencing ulcer healing and a good outcome. More recently, Yamini in 2020 undertook a meta-analysis, a review of surgical offloading, and found that within a month of bony offloading, 96% of these patients had their ulcers healed up, compared to just over 2/3 of patients within 3 months with non-surgical offloading, concluding that bony offloading is a surgical treatment worth pursuing. So I think, in summary, we've talked a little about arch mechanics, anatomy, and how tendons and ligaments support the arches. And we're all, as foot and ankle surgeons, very familiar with those concepts. And I've presented some fairly straightforward, easy surgical techniques to offload and neutralize the forces, to reduce the points of attrition where the bone might rub against this vulnerable skin and create ulcers. Prophylactic surgery is much easier. They're often done as day cases, overnight stays. It's cheaper, it's less stressful, lower complication rate, and it prevents bigger and nastier problems developing. And then you can always undertake reconstruction for the deformities that cannot be controlled, for the ones that remain vulnerable and continue to ulcerate, and TTT for all these other feet that you fail to heal with prophylaxis. So hopefully, if you employ prophylactic surgery, you can reduce your workload with reconstruction and TTT. Because feet are worth saving, as they're not just for walking. Thank you very much. For those of you that don't know Venu Kavarthapu, he's the equivalent Mr. Charcot in the UK. He is an orthopedic surgeon at King's College Hospital in London, and the surgical lead for the world famous King's College Hospital Diabetic Foot Service that's headed by Mike Edmonds. He's published extensively in this field, particularly on reconstruction of diabetic Charcot feet. He is an excellent educator and is the convener of the internationally renowned King's Diabetic Foot Symposium.
Greetings to all. I would like to thank Dr. Adrienne for inviting me to speak to you. I would probably be mid-air on a flight to Asia to attend another meeting. Unfortunately, I won't be able to join you for the discussions following the presentation. But I'm going to take you through our experience on the reconstruction of a deformed and ischemic Charcot foot. I had the largest diabetic foot reconstruction unit in the country, the King's College Hospital Diabetic Foot Unit. I'm also the current president of the International Association of Diabetic Foot Surgeons. So these are my disclosures. So Charcot foot is still an enigma for us. We still don't know many things that happen at the molecular level. But what we know is that it affects those people that suffer from peripheral neuropathy, most commonly due to diabetes, resulting in the loss of protective sensation. And if any minor trauma or any other triggering factor generates localized inflammation in the foot, that can sometimes become very severe and unregulated. And that process also overactivates the osteoclast units in that area, resulting in bone damage. And the osteoblastic response is also poor. So there may not be a good healing response. So such that a minor injury can result in change in bone fragmentations, resulting in foot shape changes. And of course, that can progress, resulting in significant deformities, point loading, and ulceration, infection, and the chain of events resulting in a limb loss. But what we know is that if that presentation is managed in an MDT environment, the outcomes are far better. And in fact, the very first diabetic foot MDT in the world was established at King's College Hospital by Professor Michael Edmonds in 1981. And within 2 years, they have noted an 86% improvement in the healing of neuropathic ulcers and a 50% reduction in major amputations. And the impact was such that the WHO recommended it as a standard of care, and it also resulted in this famous St. Vincent's Declaration. And about 30 years on, 12 years ago, my team members have gone through our outcomes again, and we were pleased to see a steady reduction in the amputation rates from our unit. And that is not just as a result of the introduction of the multidisciplinary team support, but also the complex vascular reconstruction procedures and Charcot reconstruction procedures too. But when it comes to a limb-threatening Charcot foot presentation, that multidisciplinary team should be capable of delivering complex wound control, complex mechanical control that includes deformity corrections and microbiological control. Vascular control is really critical. And in fact, in our unit is the largest complex vascular reconstruction unit, and they perform the largest number of below the ankle reconstructive procedures. And that type of support is critical too. And metabolic control and educational control. We run patient education meetings, fellowships for doctors, and various range of educational meetings and conferences. So this was the MDT 15 years ago, and there were only 2 surgeons, myself as the orthopedic and vascular surgeon, and the rest of them were podiatrists and diabetologists and administrators. And this was when we received a national award for our Charcot foot reconstruction outcomes. And this is the more recent team's photo, and some members are missing, but this picture shows 5 surgeons. Well, however, when it comes to the Charcot foot reconstructions, we have seen a marked improvement in our understanding on the fixation concepts required when we perform such reconstructions. The outcome goal should be to provide a stable, plantar-grade and ulcer-free foot that allows full weight bearing in a custom footwear without the risk of recurrence of ulcerations. For that, we need to achieve a full deformity correction and ideally a bone fusion so that the deformity will not recur in future. And we understand that Charcot neuroarthropathy affects the bone stock, bone dissolution, and even the residual bone doesn't come with a good healing potential. And of course, the soft tissue problems such as ulcerations and infections. Attempted internal fixation treatments in the past failed miserably, and even external fixation was not found to be that helpful. So I think a lot of the credit to this modern fixation concept goes to Samarco and his team when in 2010 they introduced this concept of super construct fixation. It was not until that time when we felt that it was acceptable to pass a screw along the whole length of the foot columns. And of course, that improved the fixation construct, and there were better outcomes. And that fixation principle was labeled as a durable long segment internal fixation. And as we use a standard headed screws, those can damage the metatarsal head. And to counteract that, the very first Charcot specific midfoot fusion bolt was introduced in the market by Synthes to provide that type of fixation, and we were one of the earliest adopters. But however, in this combined hindfoot and midfoot reconstruction, the midfoot fusion bolt has migrated, and that was a concern. And in fact, we have reviewed my case series of 10 midfoot fusion reconstruction patients using this particular device, and the bolt migrated in 6 of those cases, but there was no breakage. It's a solid and strong device. Satisfactory medial column deformity correction was achieved in all patients because of the intramedullary device that was possible. But when I used an additional plate fixation as well, there was bone fusion seen, and there were no migration. So that generated a new addition to this concept of, if we add rigidity to that construct with no movements in the bones, then we can expect bone healing response too, and reduced metalwork problems. So we added the rigidity to this concept. So this is the mantra we use when we do a Charcot foot reconstruction. For this fixation principle, it has to be a durable, long segment and rigid internal fixation in optimal bone position. And as a result, many modern midfoot fusion beams were introduced for Charcot midfoot reconstruction, and this particular one is one of them. So here, again, we saw these pictures before. A normal-looking foot deforms this way. So if we use a standard segmental fixation principle, using whatever device we use, they fail. And so that is not acceptable. So the modern Charcot foot reconstruction involves utilization of beams and plates. So using these modern fixation principles, and we have described various deformity patterns and the surgical fixation that can be considered for such patterns, because these Charcot deformities come in so many permutations and combinations. So it has to be a tailored approach. So let's have a look at this midfoot Charcot deformity in a colleague who works in the hospital, a very active lady. with type 2 diabetes. And if you observe, the medial column is affected. The lateral column is not affected in the Charcot process, but it is slightly deformed. And the subtalar is not affected. And her vascular studies showed poor angiosomes on the laterally. If you look at the peroneal artery, that is obliterated, I suppose, and very markedly reduced peak systolic velocity blood flow. So in that situation, the tailored approach that was used about 5 years ago on this patient was this, just medial column reconstruction using a medial approach, a wedge resection from the medial side without going through the lateral cortex of the cuboid. Very well described technique from a few of our studies. And 5 years on, she is still working in the trust, in the hospital, and mobilizing well in a comfortable pair of shoes and insoles. Well, more complex presentation in this 44-year-old recently diagnosed diabetic with severe foot sepsis that required surgery. And you can see the forefoot bones are also not great, but developed midfoot Charcot 3 months post-op, perhaps because the foot was not protected for long enough. So here, both medial and lateral columns are damaged. The subtalar looks okay, but when the lateral column is also affected, I prefer to include the subtalar joint, such as this construct used here. So it has to be a tailored approach, and the same principle is applicable to the hindfoot Charcot reconstruction. In this type 1 young lady, developed an acute hindfoot Charcot with a severe valgus instability and alignment using a durable long segment and rigid fixation with optimal internal opposition, bone opposition. So here, we have published our hindfoot reconstruction series consecutively over a period of time, but we also looked at the predictors of metalwork failure and non-union of the hindfoot Charcot reconstruction in about 74 patients. These are the surgical steps we follow when we do a hindfoot Charcot reconstruction, and when we followed these 3 steps in doing these reconstructions, the metalwork failure and non-unions were very, very reduced markedly. So a mesenile screw is this one, calcaneotibial additional screw, that improves the rigidity of the fixation construct. Again, the nail has to be long enough to achieve an isthmus fit, and if you retain the medial malleolus, that sits talus in correct position. It also provides additional rotational rigidity. So these are additional improvements in the fixation construct. But however, the limb-threatening Charcot foot presentations are often due to severe infection or severe ischemia, and we were still losing legs as a result of that until about 10 years ago. So yes, if this Charcot foot is deformed and the skin is intact, and that can be reconstructed in many centers with trained surgeons. But if there is an ulcerated foot, it adds complexity. But an actively informed and deformed Charcot foot reconstruction is a very, very high level. And now we're getting into this ischemic deformed Charcot foot with no option ischemia. What do we do? But it's really critical that the higher the complexity, the larger your MDT team, and it has to be an expert MDT team. So it is really critical that those components should not be compromised. So if you look at this infected Charcot hindfoot and midfoot in this young type 1 diabetes lady that developed a hindfoot Charcot, and instability resulted in an ulceration and infection in this chain of events. So these require staged reconstruction. During the first stage, you do thorough debridement, plan your incisions here, lateral incision, again, reach all corners like a tumor debridement surgery, and then based on your micro sensitivities, choose the antibiotic in that calcium impregnated, antibiotic impregnated calcium beads, then pack with them. Temporary stabilization. If you don't achieve the temporary stabilization, the wounds don't heal, infection doesn't resolve, as we all know. So again, we also continue with total contact casting. So monitor the wound healing response, sugar level control, and CRP response, and again, still well aligned. So after 6 weeks, sometimes 8 weeks, we take the patient back to theater, freshen up the bone surfaces, and perform the reconstruction using the fixation principles I have mentioned to you earlier. Because you achieve a stable, plantigrade, normal-shaped foot, the patient can progress to full weight bearing without the fear of recurrence of ulcerations. And we've done about 120 two-stage reconstructions so far, but this paper that was published about 6 years ago talks about 23 feet. It was the first concept published on this, on such presentations. In that group, limb salvage was achieved in all patients, and all ulcers have healed. Of course, they will heal because we corrected the deformity and provided stability. So independent full weight bearing mobilization was also achieved in a very high portion of patients. Of course, the hardware failure is a commoner problem in Charcot foot reconstructions. But if we introduce dedicated Charcot specific hardware for the hind foot as well, perhaps those complications can be reduced. But however, ischemic Charcot foot with no option ischemia remained a serious concern for us. The protocol we use for an ischemic Charcot foot is, we're talking about not the no option ischemia patients. But in our series of around 320 Charcot foot reconstructions we have done, 28% of them required perioperative revascularization from our vascular colleagues. And we're talking about below the ankle bypass surgery or endovascular procedure or any other form of revascularization procedure. These are done either a few weeks before the orthopedic reconstruction or within 6 months after the reconstruction. So if we identify any patients that have reduced vascular supply, we discuss those patients in our MDT, and such decisions are made. Again, if we do choose to reconstruct these vascularly post-operatively, that will also be offered. But how about no option ischemic Charcot foot? And we had a few of those. Even our vascular colleagues weren't able to improve the circulation, and they actually had to perform 2 elective below-the-knee amputations on 2 patients for that. But we feel that this new TTT concept might save some of those. I'm not going to go through the TTT concept in detail. You have fantastic lectures in the program, but we're talking about a patient with Charcot foot as well as ulceration. And this is the first such case perhaps reported in the world. This 54-year-old gentleman who had a transmed amputation on the opposite side and developed a right midfoot Charcot and a non-healing ulcer. And this is despite using all methods we have at our disposal. And multiple revascularization procedures have failed. And essentially, they recommended a below-knee amputation. But we attempted this concept on this patient for the first time. This was done about 3.5 years ago, and this case report is currently being published. So what we did, again, using the same principles, the midfoot reconstruction was done using the smaller sized incisions, and a frame on that occasion was applied, and the tibial cortex transport was commenced. So at 3 weeks, all wounds healed completely, and the frame was removed at 3 months, and then the patient transitioned into a total contact cast and the shoes when the shoes became available around 4 months' time. So we could not even dock the cortical window back completely, but it's amazing that the ulcer healed and remained healed. The foot alignment correction stayed even after 3.5 years, and we saw quite an abundant bone formation. So we don't know much about this principle fully as yet. But another case is the second case, and the first case with this mini fixator we use. And I had to go through extensive institutional clearances to do these two cases. So in this 74-year-old gentleman with marked midfoot Charcot and non-healing ulceration. Again, I've done the first stage of the procedure, and during that first stage, debrided the ulcer, took bone biopsies, did bone debridements, and improved the deformity as well. And the ulcer healed. The wound healing response was slow, but eventually healed. And then I removed the wires. But the patient has to have the revascularization procedure before we can proceed to the second stage. But it is a desert foot, and the vascular colleagues suggested that there was no way they could improve, and any surgical reconstruction carries a high risk of limb loss. So for that patient, again, used the TTT concept using a mini fixator, using a small incision, minimally invasive approach, freshened up the midfoot bones, corrected the deformity, and using an MIS burr, prepared the ankle joint. I didn't want to use a hindfoot nail with a larger incision, so used the midfoot fusion beams to fix the hindfoot in a compressive mode. Again, correct the midfoot further using the MIS burrs, line up, and used multiple midfoot beams as well. So residual toe deformities were corrected with the MIS burr. Again, cortical window made, mini fixator applied, tested if that transports well enough, and then started the program. So the picture on the right side, the X-ray shows the cortical bone docked back in. That was about 6-week mark. And again, we had about 2 months, we have seen good bone healing, wounds healed well. And this is now about 8 months post-surgery. And again, the bone healing response has been good. The ulcer stayed healed, and the patient is mobilizing, full weight bearing in a custom pair of shoe, and has a reasonable activity level. So in conclusion, yes, we are learning a lot more about Charcot foot reconstructions. There's still so much more to learn. But yes, a deformed, actively infected Charcot foot can be reconstructed, but this is in addition to our department. An ischemic deformed Charcot foot, selective cases can be considered for such new treatment methods. So with that, I would like to re-emphasize that it is really critical that this survey should be supported by the appropriate sized expert MDT team. So if you follow the modern fixation methods and have the support of a specialist MDT, we can save many of these limb-threatening Charcot foot presentations. With that, I would like to thank you very much for your attention. It's a fantastic program, and I'm sure that you will enjoy all talks amazingly well. I'm sorry that I'm going to miss listening to those talks. If you like to know more about the multidisciplinary surgical approach and a dedicated full-day sessions on advanced Charcot foot reconstructions. Our meeting may interest you, and I very much look forward to welcoming you in London in October. Thank you very much, and I really appreciate for your time.
Thank you, Venu, for taking the time to record your talk. I can wholly recommend the King's Diabetic Foot Meeting. It's an excellent venue this year, and you have all the delights of London in the autumn to enjoy. So I'd like to transition to our next speaker, Professor Alexander Kirienko. He is the head of Division of External Fixation and Bone Lengthening at the Humanitas Research Hospital, and a devotee of Elizarov osteosynthesis in the treatment of complex foot deformity. The screen is yours, Professor.
Thank you very much. I hope you hear me. Yes?
Yes, sir. Yes.
Perfect. Again, okay, I'll share my screen, and I go to the presentation. The first, I want to say thank you, Alan, to invite me to this Congress. Not easy to talk for the last, but it's really a pleasure because the many people resisted and wait for my presentation. I want to talk about the story about the TTT and Elizarov technique. And like you know, this Bible, like Elizarov osteosynthesis, just described this transfer transport. And we should go to stories. The first description of the transfer transport was described in 1972 because Elizarov and Ledeyev, they do this patent of the bone transport. 72, remember this date. And in Elizarov clinic, there was an experimental department, and they studied experimentally on the animals how it should be done, this transport. And it was a rhythm of distraction was chosen to 1 millimeter because a faster distraction provoke a really slow regeneration and necrosis of the bone. Like you see here, with the rhythm of 1.9 millimeters, the bone formation is really slow and no good. This principle of the treatment have a possibility to resolve many orthopedic problems. Like you see in this case, it was done the transport of this small fibula, and it was built practically new tibia with this lateral bone transverse transport. Another clinical case, again, this is reprinting the bone defect of the tibia with the transport and reprinting of the continuous of the tibia. Many studies was done about the new vascularization. We have in Elizarov clinic different apparatus, and we have an electronic microscope to study formation of the new vessels during this kind of the treatment. And like you see, here is another animal model that is a larger of the ulna of the dog, demonstrate how big improvement of the blood circulation demonstrated with the angiography. Another improvement of this method and the study of this method was with this patent in February 1976. This patent talked about largening and lengthening of the tibia and forearm. And here was proposed to do largening of the fibula, was osteotomy, bifocal osteotomy, and lengthening of the tibia. This was used for largening of the bone because many patients with polio in this area was, and the many ladies, women, wants to do enlargement and improve the thickening of the leg. Like you see in this clinical case, shortening of the leg, really thin tibia, and the Rezarov technique permits to do lengthening of the tibia and largening of the tibia. Now I shift to my personal story, because I was born not so far from Italy, obviously, and not so near from the Kurgan. I live in Blagoveshchensk, Amur region. It is a practically east part of the Russia, more near of Japan than to Europe. This is my city, Blagoveshchensk. It is it's found in the where two big river Amur and Zeya cross it, and they divide. In this, there is a frontier between China and Russia. When I have finished my medical school in 1982, I go to Kurgan, because Russian Ministry of Health sent us to another region. It was this colleague works there with Elizarov chief. It was only old building, only four floor building, and this is my department when I start working, and orthopedic for the adults. In this orthopedic clinic, we do a new technique. For example, it was the firstly approved lengthening of the stump of the foot, and from the stump of the tibia, we created the new foot with this method of the reconstruction. It was a treatment with the patient with the amputation of the tooth, treatment of the syndactyly, and the different experimental studies. In this period, Elizarov thinking about the new building. In this, when I come there, 92, it was like this, and it was in a reconstruction. And we walk up to Elizarov again in the old building, and he organized a few congresses in there. And finally, in 1983, it was open new building, and this building was open the new department. In the new department was one of them was Department of the Hand and Foot Surgery, and I worked in this department. Like you see here, we occupied to do, for example, lengthening of brachymetacarpia. And this is our department. This chief was Murashka, and we work with Elizarov again, but in this clinic, in our department of foot and head surgery, we do many surgery. Personally, I do many of them for this principle of largening of the bone. We do this kind of treatment, more complicated I described before. We do osteotomy of fibula, tooth, 3 levels, osteotomy of the tibia, and osteotomy for lengthening altogether. And this is how it looks radiologically, how it looks schematically. And in this kind of treatment, Elizarov and the experimental studies, they noted that it was a big increase of volume and rate of blood flow with this transfer. Like you see in this schistogram, demonstrate really big improvement of blood flow in the area of the bone transfer. And Elizarov, it was really a cute man, and he patented this method in 1983. It is a method of treatment chronic ischemia of the limb. And this is again my picture with Elizarov in my department. I worked because I became the chief of department in 1986. And this is a journal of USSR. It was this picture. And this, we worked with these children with the malformation of the hand. And the principle of the treatment of ischemia demonstrated in this scheme, because we do the big fragment of the tibia. It was maybe half of diaphysis, and the destruction rhythm was 1 millimeter, but later one, Elizarov afraid that will be slow regeneration, and we do 0.5 millimeter a day of lengthening. But this demonstrate really big improvement of the blood circulation, like you see here. This is a pulse of the peripheral artery and the arteriogram. We do it before and after treatment, and like you see here, improvement really amazing with kind of treatment before and after treatment. And this is before treatment in geography, during treatment, and after finish the treatment after 6 months. In any case, indication of this treatment was not diabetic food, because Elizarov in any case was afraid of diabetic food. It was really complicated this time, and more of the patient was with thromboangiitis, obliterans arteriosus, obliterans renal disease, and we limited really difficult case was not treated in this area in this period. This is Dr. Piley. You know him. He came there in this period to have a fellowship in Kurgan. I continue work with Elizarov, and I don't occupy personal this patient, because I occupy more with the foot disease and hand disease in clinic of Elizarov. But it was one department. They do continue to do the treatment of this ischemic patient with a really good result. In 1992, again, I continue my personal story. I moved to Italy, and we published some book, and in any case, I follow a little bit of this kind of the treatment with bone transport, and it was similar patent in Russia in 2001. They do this bone transfer with more smaller distractor, and firstly, they do the compression and destruction of the bone fragment, because when I work in Elizarov, we do only destruction and never do this movement, destruction and compression of the bone fragment. And I occupied again of the foot surgery. I do this book. And what about the treatment of diabetic patients that they do now in Italy? Usually I don't do again, or I don't know, maybe I will do it for sure, with a small fixator, because we have really good approach. We have a vascular surgery. They do usually revascularization before doing the treatment of the Charcot foot. And usually I do this kind of treatment, the Charcot foot with the deformity and ulceration, where there is a really bad deformity of the foot. Like in this case, the patient have ankle arthritis, and we do here pantalar arthrodesis, calcaneocuboid, navicular subtalar, and the ankle joint arthrodesis. This is how it looks. Meanwhile, there is a wound here. We apply the frame. We remove all the cartilage, and how it looks the wound at the end of the surgery. I don't permit the patient weight bearing on the foot directly. We put this kind of rails for weight bearing, and how this looks during the treatment. And this is the frame during the surgery of removing, and how you see here also completely healed, because he weight bearing now really good. And we keep this brace for 1 month, and this is a radiological view after 3 months and clinical view of the foot after 3 months. Another clinical example is this typical Charcot foot with the female with this dislocation of Lisfranc joint, and he was really good for 6 months, but one time we look here, no control. After 6 months, we see that it was completely necrosis of the talus. We should do another surgery. We did a calcaneal tibial arthrodesis with the frame. Another clinical case really bad. They should treat in Italy this kind of person. Is a young lady with diabetic 1 form. And many surgery, internal fixation, but like you see here, dislocation of the complete dislocation of the ankle. And we do the 2-step surgery. The first, I apply the frame for progressive correction of this bad valgus, and we put in the plate integrated. When we realign it, I did open surgery, arthrodesis of the ankle joint. It looks really nice, but unfortunately, he deformed it again, and it was like a fibrous ankylosis, and he developed again some kind of ulcer anteriorly. But this time I don't do arthrodesis because it was really rigid fibrous arthrodesis. I do only osteotomy proximal, distal proximally to the ankle, distal tibia with the progressive correction, supramolar osteotomy. And like you see here with this surgery, he's healed completely with a good great foot without ulcers. And now she's 2 years without any ulcers. And I do some promotion. I have 1 minute again, because in 2030, we want to organize the World Congress of External Fixator in Milano, where I live now. And why we choose this date in what we want to dedicate? Because it will be 50 years of one event. This is a really important event. Carlo Mauri, he's an Italian explorer. He go to Elizarov in 1980 because he have a really bad problem with the tibia and the foot deformity. And Elizarov operate him on 4 April 1980. It will be exactly 15 years ago. It was the first stranger was outside from Russia. He was operated in Kurgan by Elizarov. He have this treatment. I recovered this clinical story of the patient, clinical documents. Carlo Mauri, Carletto, they call it. We do always the picture before and after surgery. This is his clinical story with the anamnesis. And I invite you to come to Milano in 1930. It's really easy to arrive to Milan by plane, and we have a really big Congress hall like this one, this MICO, the Conventional Center, this really big amount of hospitality and big halls for congresses. And we achieved the confirmation from the president, Chinese president, Professor Shang-Chi, for the possibility to organize this Congress in Milan. Thank you very much for your attention.
Thank you, Professor Kirienko. A fascinating insight. I particularly enjoyed the training photos you took from Russia. Wonderful to see those that historical perspective. Anyway, moving swiftly back to America, it gives me great pleasure to welcome to the screen Dr. Estes, who is a double board certified podiatric foot and ankle surgeon based in Southern California. She's a consultant and a speaker on behalf of Orthofix, who we are grateful for sponsoring her appearance on this meeting. She's published extensively on TTT. She is an associate professor at the Western University of Health Sciences, serving as director for continuing education for the College of Podiatric Medicine. She is also chief of podiatry at Riverside University Health Systems. Thank you. The screen is yours.
So, wow, what a day. I really enjoyed everything about today. It's been a treat to be amongst legends in the panel today. So thank you for that, especially for Dr. Kirienko. What a treat. So it's a great honor to share our early experience in front of all the experts and participants who've led this technique with thousands of successful cases. In the US, we've recently begun to re-engage with this powerful concept of using a modernized system design to make the procedure more precise and accessible with the newly launched TrueLock Elevate transverse bone transport system. Again, I'm Dr. Adrienne Estes. I'm coming out of USA, and it's a pleasure for me to lecture to you and on behalf of Orthofix. As many in the room know, the foundation of our work rests in the revolutionary principles by Professor Elizarov in the mid-20th century. He pioneered this distraction osteogenesis, which was vastly discussed today, not only for lengthening bone, but for regenerating bone and soft tissue under controlled mechanical tension. His technique on the corticotomy and the gradual distraction obviously opened major frontiers in limb reconstruction and allowing us to regenerate bone and improve the local vascularity, which are concepts that remain key to today's day and age. So Elizarov, obviously, Dr. Kirienko already talked about his early forms of transverse bone transport, applying these principles to the problems of ischemic ulcers and chronic infections. And this obviously has laid the groundwork for what we're trying to do today in high-risk limbs, particularly in our diabetic patients as of now. So with this device, we are essentially building the foundation that Elizarov pioneered. The Elevate system was designed specifically for ease of use, precision, and reproducibility. You can appreciate the safe and controlled distraction mechanism on this easy to use knob dial at the top of the device. And our aim was to simplify the application and reduce variability in the distraction while preserving the biological benefits that this group so powerfully demonstrated today. The instructions for use of the TrueLock Elevate system is intended to correct bony or soft tissue defect deformities, making this a great resource to piggyback off of our current TrueLock fixation device that's out there. So we have found the Elevate system in its early adoption has shown not only reliability for external fixation, but it supports consistent and controlled transverse movement, which we believe is the key to reproducible vascular outcomes. So here you can appreciate the device can be applied as a standalone, or it can be encompassed with a multiplanar ring formation, depending on your pathology, if there's something else that you are addressing. The standalone itself does have a bicortical static bar that is intended to reduce the stress on the fixator. And we use 4mm half pins for the bone transport segment, as well as 5mm half pins for the static bar to support the device and improve stability. Currently, the indication for this device can be utilized along the entire tibia. We are currently looking into its applicability when it comes to distal application right now, but we're looking at means of some of the concerns that obviously would be raised in this situation, such as accommodating thinner skin, a narrow bone canal, as well as the concerns of how to work around the curvature of the distal tibia. The size of the device is relatively compact to really lean into a more minimally invasive approach that was already mentioned by Dr. Lee. The half pin lengths are 120mm, which you do anticipate to cut. We have a shorter thread length, 18mm, for the actual bone segment transport itself. And we realized that a template model dedicated to the surgeons were very useful. So you can have reproducible corticotomies, as well as having guide tubes that can accept both wire and drill inserter guides for the final half pin construct placement. The device will also accommodate very nicely up to 24 degrees for the half pins if necessary. And the X-Fix will be secured with to the half pins itself by means of fixation bolts and 3 flat nuts and 1 spherical nut. Now, we use the spherical nut specifically because we're taking advantage of a spherical nut's self-aligning capability. This will allow for it to compensate on a non-parallel surface that we have on one of the vertical slots on the dynamic bar. And this will ensure that you can have proper load distribution, and it will reduce the stress on the construct. This was a rather impressive new tool specifically designed for this device only. It has 3 terminals you can appreciate here with a drill positioning guide for the pilot holes of the corticotomy. It also allows you to unscrew the pin guides once you remove the template at the end of the case, as well as we have 2 variable drill guide templates. One is an X and one is an I, and the purpose of this is to allow you to drill along the template guide cutting guide for well approximated placement, both on the sides as well as the corners. And finally, which I can't demonstrate here, but the device itself has an end stop for the drill. And I think that is very helpful so that you have even pilot holes in anticipation for your full corticotomy when you do the bone transport segment. So to distract the bone segment, there is a knob on the device that you pull upwards, and you're going to rotate that counterclockwise, following the direction of the rotation indicated by the arrows marked on the device. Each click will accommodate 0.25 millimeters of movement with a max distraction capability of 14 millimeters. Now, based on the data, turns can be seen anywhere from 0.5 millimeters up to 1 millimeter a day. And we have found some patients, at least in our cohort, with the 1 millimeter a day has sometimes put too much tension on the flap. And so we do encourage you to closely monitor your patients, engage that distraction planning with the sensitivity of how your soft tissue envelope is responding to the distraction, especially if you want to pursue doing a distal application. So for the sake of time, we will not go into step-by-step of the procedure, but instead we'll focus on some surgical pearl techniques for the audience. So you want to confirm the template placement is below that anterior tibial crest on a lateral view. That way you confirm no risk for stress risers going into the anterior tibia. You will want to drill the pilot holes of the corticotomy around the template, and we use a 2.7 non-cannulated drill bit. And you want to accommodate about a 3 to 4 degree angle to form a trapezoidal shape. And the reason for that is because you want to prevent impingement of the transport segment. Next, you're going to complete the corticotomy, and you can do this with a narrow osteotome or a sagittal saw. I myself use a sagittal saw, but you're only going to complete the anterior, proximal, and distal sides, as we will complete the corticotomy on the posterior margin after your X-fix is placed, so that you have a stable fixation ready to go prior to creating that unstable bone transport segment. After the half pins have been placed, you want to make sure you're going to cut your 4 millimeter transport segment half pins, and you're going to do this at a marked level. And the reason you do this is because you want to accommodate room for the diverging 5 millimeter bicortical half pins that are planned for the static bar, as you can see here. Now, once this step is done, you can go ahead and complete your posterior corticotomy side. And finally, you want to check fluoroscopy to not only make sure that your insertion of the static bar are bicortical, but also you want to then confirm mobilization of your bone segment and make sure that is able to be elevated and be able to redock into the bone. Next, we will review some surgical flap techniques, pearls to consider. So you want to make sure that you carefully plan your template positioning at a minimum of 4 millimeters from the tibial tuberosity. And then many times our incision approach, there's been many tried and true from what I've seen, but I think what we have found is that a posteriorly arced incision, it's approximately 100 millimeters long on the medial face of the tibia, has shown to have excellent flap versatility, including it staying into that PT artery angiosome of the medial leg. And it gives you a wide view of the tibia for the template placement and corticotomy once you elevate your flap. So after dissection, you want to do a no-touch technique of your flap and suture it out of the way. Next, you're going to position your template guide over the periosteum, and you want to confirm position under your fluoroscopy one more time. And here you can appreciate the pilot holes created around the template with a 2.7 drill bit around the template guide. Now, once you've completed your, with a sagittal saw or osteotome, your anterior, distal, and proximal sides of the corticotomy, you're going to redistribute your flap over the 2 pin guides and the temporary fixation pin. Once you've secured your X-fix half pins and completed the posterior wall of your corticotomy, you can go ahead and proceed with closure of your flap per your preference. So many wonderful cases and solid studies have been shared today, much more robust than I would ever be able to do today, showing the successful outcomes of the transverse bone transport. And we have published on the technique guide, as well as we have published on the distal transverse tibial bone transport as well. And we have a case series and a multi-center on the success rate of the limb salvage rates with the use of the transverse bone transport segment in the US. So our panelists have demonstrated quite effectively the impact of the transverse bone transport in general, as well as the benefits of a proximal corticotomy and limb salvage internationally. But of course, its application in the US has been a bit limited because of our infancy using it, given it's just been released on the market not too long ago. So one thing that we wanted to look at was evaluating if distal corticotomies are successful as its proximal counterpart. And so far, I think that we are happy with the results. As some in the audience may recall, there has been studies looking at longitudinal distraction osteogenesis of the distal tibia that's been reviewed with success that's near about the same as a proximal longitudinal distraction. But currently there are no studies directly comparing its proximal counterpart. So we've been looking currently just to see if it creates that prolonged hypervascular environment in the distal extremity by doing it in the distal tibia versus just a proximal corticotomy. So our hopes are that we see the same outcomes demonstrating that enhanced neovascularization. And so we are collecting cases to demonstrate that it does have some effectiveness close to the proximal. And as stated earlier, its success is not only based on that local hypervascular response, but we're also looking at the fact that we're taking benefits of that systemic response of the mechanical traction created by the transport in general. And so you can appreciate that the distraction histiogenesis with the regenerate tissue and hypervascular response is there. So although our data is low and possibly less robust in terms of outcomes compared to a proximal corticotomy, the importance is we are seeing a response in that distal technique. So here's just some cases that we are looking at by doing a distal transverse bone transport at this time. So a patient gangrenous case, and obviously over time, these cases have demonstrated very similar needs based on our international colleagues, that a lot of these patients require adjunct therapy. This is an adjunct procedure. This is not a standalone itself. A lot of them do require serial wound debridements as well as potential allograft placement. And this was very common in the cases that we've seen, and therefore we should assume to expect the same for these type of patients. And our healing time has averaged anywhere from 6 to 9 months, which is comparable to the studies out of China where they've ranged from 4 to 7 months. And so far we're happy to say that we are showing some healing limbs. Here's another patient demonstrating an impressive granular response despite the fact that the initial amputation did necrose. And we still proceeded on with salvage. And you can see at 9 weeks, you have a nice hypergranular base. So grafting was proceeded with. And you can see that even at 6 months, they're doing very well. Here's our most recent case that we did 2 months ago. This was a patient who had we'll say a partial healed transmetatarsal amputation, had multiple attempts of salvage because he didn't want a more proximal amputation. He's been doing HBO, we've done serial debridements, wound grafting, wound care, and he's had multiple vascularization attempts. So we had been asked actually by Vascular if we could attempt a transverse tibial bone transport, to which we did, as well as alongside a surgical debridement. Unsurprised, serial debridements were continued, and this patient we opted to start debridements actually much sooner than our previous patients, just to see if it was beneficial to the patient. So we did start grafting at 3 weeks, and you can see even at 6 weeks, we are showing an actual much better response in terms of healing potential. And obviously we'll continue following this patient given the excellent response onto healing. With this, I want to thank Orthofix for the opportunity to lecture on their behalf and for sponsoring this tremendously successful event. And so obviously overall, it sounds like we're all just hopeful where tibial bone transport is going. And Orthofix Elevate has been successful with hundreds of cases to date in the US across many states. So we do look forward to further research to optimize the surgical technique. We're going to be looking at the torque impact on the standalone device. We are aiming for this minimally invasive application of a much smaller construct as opposed to a full ring construct. We're hoping to fine tune, this is everything everyone has said, but refine that patient selection criteria, do comparative studies looking at proximal versus distal, and really continue to understand the tissue regeneration as it continues to evolve. So I look forward, I'm sure everyone here, building a strong community amongst other surgeons and physicians nationally and internationally, so we can overall improve quality of life and reduce these major amputations for our patients with pretty complex limb-threatening conditions. So that is it, and thank you for your time and attention.
Thank you, Dr. Estes. Your talk brings us to a conclusion to all the presentations. It's been a fascinating day. Before we move on to the question and answer section, which I'm sure all of you are keenly holding out for, I'd like to take this opportunity to thank our very generous industry sponsors for supporting this forum, without whom it would not take place. Our gold sponsor is Orthofix, and then we have our next level silver sponsors, Vilex, Fusion Orthopedics, Paragon 28, and Blue Ocean Global. And our bronze sponsors, Unite Foot and Ankle, Synaptic Surgical, Induce XT, Husia Osteotronics, Restore 3D, Bojin, BFix, and Leith Medical.